Okay, hiatus hernia. So a hernia, and we'll come to hernias later, but a hernia is basically when any part of one organ or tissue migrates or moves into another compartment where it doesn't belong. So a hiatus hernia is where the upper part of the stomach, just a part of it, moves above the diaphragm where it doesn't belong into the chest cavity. Okay, so you can see that now the lower esophageal sphincter isn't exactly where it's supposed to be because part of the stomach is herniated up. So it doesn't have the same effectiveness anymore. So if you have hiatus hernia, you're basically just more at risk for gastroesophageal reflux. Okay, um, and when you get chronic gastroesophageal reflux from any of the things that we spoke about, whether it's obesity, whether it's from chronic straining because you're constipated all the time and you're increasing your abdominal pressure, so you're forcing acid into your esophagus, anything that's forcing acid and causing you to reflux acid into your esophagus puts you at risk for the listed complications. Okay, so it's not specific to hiatus hernia, these complications. Those can happen with anyone who has GERD. Okay, so if I was to change the slide a bit, I would say these are complications of gastroesophageal reflux. And what are they? They're stenosis, ulceration, aspiration, and Barrett's dysplasia. And hiatus hernia is just one of the risk factors for getting GERD. Okay, so what's stenosis? So esophageal stenosis, well, let's start with the most common one. Just esophagitis, inflammation of the esophagus. Okay, that's what we typically call heartburn. As the years go by, though, the inflammation is now going to lead to potential ulcers in your esophagus because the acid keeps on refluxing. So now you have some ulcers in your lower esophagus plus the inflammation. And then as the years go on, there's going to be some scarring there, and it's going to lead to a tightening or a stenosis of the lower esophagus, which is going to make it difficult to swallow certain foods, especially chunky foods like meat and chicken. It'll get stuck. So GERD can lead to stenosis of the lower esophagus. Aspiration. Well, we already mentioned that acid can reflux all the way back up into your mouth, and a bit can leak into your respiratory system through your vocal cords and cause some aspiration and a chronic cough. Okay. And lastly, Barrett's esophagus or Barrett's dysplasia is just that the cells of the lower esophagus have been so irritated from esophagitis and ulcers that they're now becoming abnormal when we biopsy them. We take a biopsy, we look into the microscope, and we see that the cells are now almost precancerous. Okay, so Barrett's esophagus or dysplasia, those are precancerous cells, okay, before esophageal cancer occurs. So how do we treat gastroesophageal reflux disease or hiatus hernia? Remember, hiatus hernia is just the mechanical position of the esophagus and the stomach. The symptom or the what's happening is gastroesophageal reflux disease. So how do we treat it? Well, we can treat it with antacids to lower the acid that's refluxing, to lower the acids or raise the pH so that when it does reflux, it's not burning the esophagus anymore. And lastly, there are some surgeries we can do near the lower esophageal sphincter to tighten it up a bit so that reflux is much less common. Okay, so this is the most common complication of gastroesophageal reflux disease, and it's esophagitis. inflammation of the lower esophagus typically. Okay, and you can see the differences from the two sides. One has it's nice and pink. The other one's a bit scarred, a bit irritated, a bit pale looking from the inflammation and the acid that's being refluxed. Okay, so if the reflux were to continue for years, you're now going to get into the possibility of scarring the lower esophagus. And when you scar the lower esophagus, it doesn't open and close as well anymore. And as it scars and tightens and becomes a narrower, the tube is much more narrow now. Certain foods can get stuck, and that's what we call either a stricture or a stenosis. And it's typically meats that get stuck: chicken, different types of meat, a piece of steak. And if it does get stuck, it has to be taken out with a scope, with a gastroscope. Go down, remove it with the scope, or break it up and push it through. And encourage people to really chew their food well before swallowing, otherwise meat will get stuck again. The other thing that sometimes needs to be done with a stricture or stenosis is that we'll go across it with a tube, a gastroscope, and then it'll be dilated. Okay, so the stricture or the tightening will be dilated open so that food isn't getting stuck all the time, and that is commonly done as well. Okay, ulcers. Well, you can definitely develop ulcers if you have severe gastroesophageal reflux disease. Okay, from any of those causes. If you're getting acid bathing your lower esophagus on a daily basis, it's going to become very inflamed and potentially ulcerated, and that's what we're seeing here. Okay, so what's Barrett's esophagus? So mentioned before, the Barrett's esophagus is it's a precancerous cellular change of the esophageal cells, and it's really from chronic damage, from either chronic reflux disease of acid that's been irritating the cells. Smokers, so when you smoke, you actually swallow a lot of toxins down your esophagus, right? You don't just inhale smoke, you actually swallow because it gets deposited on your tongue and your pharynx. So that irritates the esophagus, and alcohol is an esophageal irritant. So what are the risk factors for esophageal cancer or Barrett's esophagus? So chronic reflux of acid, being a smoker, and heavy alcohol drinking. They all irritate and inflame the lower esophagus. And whenever you inflame any area of the body, you force the cells to divide a lot. And finally, one of the cells has a mutation, and that can lead to dysplastic cells or cancerous cells. So here we're looking at esophageal cancer, which is a very aggressive cancer. Lung cancer is also an aggressive cancer. Pancreatic cancer is one that we'll talk about a bit later, another very aggressive cancer. And the risk factors are basically anything that's going to irritate the esophagus and cause it to cause the cells to frequently divide and finally lead to a mutation over many years. So smoking, alcohol, chronic reflux disease, those are all risk factors not only for esophageal cancer but also for the precancerous condition called Barrett's esophagus. Okay, and remember remember the symptoms. When we're talking about diseases, try and think of the symptoms or ask what the symptoms are. This person would come in saying, I'm having difficulty swallowing food. Okay, well, that's a bit concerning. You can't get the food down, so that means there's a narrowing. So likely set up a gastroscope for someone with that symptom. And if it really progresses fast, it'll come back and say, I can't swallow food or water any longer, because not even the water can get through the obstruction. Whereas before, the food couldn't get through and the water could trickle around it. But if it completely obstructs the esophagus, then nothing can get through. Okay, so a brief slide here, stomach anatomy. Remember the lower esophageal sphincter, which prevents reflux of acid back into the esophagus. And also the pyloric sphincter, which is a bit of a valve that allows flow to go from the stomach into the duodenum. Just an interesting note on the pyloric sphincter. Small children, young infants, can actually have a complete blockage of the pyloric sphincter. And that's typically a surgical procedure to repair it. And how do they present? Well, they present with projectile vomiting. Nothing can get through when the stomach is contracting. And finally, the vomit comes out very forcefully, and we call it projectile vomiting. Anyways, so there's circular layers of muscle that can squeeze the stomach, and there's longitudinal layers of muscle that can move the stomach forward towards the pyloric sphincter and into the duodenum. So what's the main function of the stomach? It's really to accept food from the esophagus, to mix food with a very acidic gastric juices, and to start the digestive process with pepsin, which will start to break down proteins. So it'll mix the food. The stomach is also a storage. If you didn't have a stomach, you wouldn't be able to eat very much at any one meal, because it would just go right to the duodenum, and you'd be full within a mouthful, with having eaten one or two mouthfuls. So the stomach can also store food. Typically, food stays in your stomach for approximately 2 hours, where it mixes with the acid, starts to break down the proteins with pepsin, and it turns into chyme through the mechanical digestive process, where the stomach is continually contracting to turn everything together and mix it into a chyme liquid that can then be sent to the duodenum. There's very few things that get absorbed from the stomach. Aspirin, alcohol, and some electrolytes are absorbed in the stomach. Remember, the small intestine is the main absorption area for nutrients and basically all other things except for fluid, which is absorbed in the large intestine. So the pyloric sphincter opens when the content is ready to be dumped into the duodenum, and that would be the chyme. So there's a few different cells that make up the stomach wall. There's some cells called chief cells. What did they secrete? Well, they secrete an enzyme that's going to start the process of breaking up proteins. It's called pepsinogen. Pepsinogen converts to pepsin in the presence of acid in the stomach. So the active enzyme is actually pepsin. Parietal cells, well, we've spoken about parietal cells. Their main function is to produce hydrochloric acid to keep a very low pH in the stomach, and that's where many of the medications that we use to lower acid secretion from parietal cells, they function there. Your ranitidine, cimetidine, the PPIs, they act on the parietal cells. The parietal cells also produce intrinsic factor, which is a molecule that basically chauffeurs vitamin B12 that you've eaten through the small intestine and gets absorbed in the distal small intestine called the ileum. Okay, so you need intrinsic factor from the stomach to absorb vitamin B12 in the ileum of the small intestine. Okay, so without intrinsic factor, for example, if you've had surgery that's removed your stomach, or if you have a very diseased stomach and you're not producing intrinsic factor, then you're going to have poor absorption of vitamin B12. And we call this condition pernicious anemia. So pernicious anemia is because you are not producing intrinsic factor for a number of reasons. And then because you aren't producing the intrinsic factor, you become vitamin B12 deficient. And vitamin B12 is needed in the bone marrow to produce mature red blood cells. So folate and vitamin B12 are two nutrients or vitamins that are required to make mature red blood cells. If you don't have vitamin B12, or if you're deficient in vitamin B12, you will have large red blood cells that are immature, and that's why we call it megaloblastic anemia, because the red blood cells are large. They didn't mature and become smaller because you didn't have B12, so you develop a megaloblastic anemia. So your hemoglobin is lower, and what do the cells look like? They're larger because they didn't mature. Goblet cells are just cells throughout the whole intestinal tract, and they basically produce mucus to keep everything flowing properly, and also to protect the stomach from the very large amounts of hydrochloric acid. Brunner's glands, they do the opposite. So at the beginning of the duodenum, does the duodenum really want to see a lot of acid pouring into itself and causing a duodenitis, let's say, like inflammation of the duodenum? No. So these glands secrete alkaline solution to neutralize the acidic chyme coming from the stomach. So they're prepared to neutralize the acidity of the chyme so that you don't harm your duodenal lining. Okay, so let's talk about upper gastrointestinal bleeding. So basically, upper gastrointestinal bleeding means bleeding typically from the esophagus, the stomach, or the first part of the duodenum. Okay, so what causes bleeding from one of these sites? Well, let's start with the esophagus. So the esophagus, as we know, we can get esophagitis, which is inflammation of the esophagus. And that inflammation can actually drip a bit of blood down into the stomach and then go on through the large intestine to your anus. So you can get some bleeding that way. You could vomit up the blood, and we'll talk about the different names for whether you're vomiting or whether you're having blood in your stool. So esophagitis can cause it. What about dilated veins in your esophagus? So they're called esophageal varices. And the concept's a bit important to understand here. So this condition is people with cirrhosis. So all the blood supply from the gastrointestinal tract flows through a vein called the portal vein, and it has to go. The portal vein drains to the liver. The liver does the processing of everything that's returning to it, such as the nutrients, the vitamins. So if you have cirrhosis, you actually have severe scarring of the liver, and that includes the blood vessels that are returning to the liver. So when you have scarring of those blood vessels, including a huge one called the portal vein, the blood can't return to the liver, so you get backup of pressure in the portal system. And one of the effects of high portal vein pressure, because you have cirrhosis, is dilated veins in the gastrointestinal tract. And the one we're talking about right now is esophageal varices. So varices is just a fancy name for dilated veins. You can get gastric varices. You can get varices anywhere because the drainage of the portal vein is blocked by the cirrhotic liver. Okay, so esophageal varices are basically dilated veins in the esophagus. And because we're eating, we can tear a vein. We can irritate a vein. So if it tears one of these esophageal varices veins, they can really, really bleed. There's really nothing to stop the bleeding, to put pressure on it. Okay? So next, gastritis. Well, gastritis is the same, is basically inflammation of the stomach from any cause, whether it's a drug such as a non-steroidal anti-inflammatory or steroids that someone's taking for their asthma flare-up. They're gastric irritants, and they can create ulcers as well. But even gastritis by itself, which is inflammation of the stomach, can lead to bleeding. Ulcers. Well, ulcers can definitely lead to bleeding. If an ulcer happens to be near a vessel, and as the ulcer gets deeper and deeper, it perforates the blood vessel, you can get tremendous amounts of bleeding from a gastric or a duodenal ulcer. GERD is really the same as saying esophagitis, right? So GERD is a reflux of acid causing esophagitis. Sure, you can get bleeding from that. Cancers. So whether you have an esophageal cancer or a gastric cancer, those cancers, as they grow, they're very abnormal cells. They have abnormal blood vessels going to them, and they can cause bleeding from the esophagus or from the gastric tissue. Okay, so let's talk about upper gastrointestinal bleeding a bit further. So where is the bleeding coming from? Well, typically upper gastrointestinal bleeding is the esophagus, the stomach, or the first part of the duodenum. Okay, and if the bleeding heads down the gastrointestinal tract, it will result in melena, so black stools. Okay, so why is it black? Well, the blood has had time to be digested as it's going through the gastrointestinal tract, and it results in black tarry stools that have a very distinctive smell. In fact, once you've smelled melena, you'll never forget it. Okay. So let's talk about hematemesis. So hematemesis is the vomiting of blood. Okay. It can still come from the esophagus, the stomach, or the first part of the duodenum, such as a duodenal ulcer, or a stomach ulcer, or stomach cancer, or what we call esophageal varices, dilated veins in the esophagus, typically typically in someone with cirrhosis of the liver. Okay, so hematemesis can occur from any of those sites, and with vomiting, then blood comes up. Okay, now typically, if it's from the esophagus, it hasn't mixed with the acid of the stomach yet, so it comes up as bright red blood. If it's had time to mix, or if it's had time, or it's just occurring within the stomach or the duodenum, then there's mixing of blood with acid in the stomach, and it comes out in the vomit as what we call coffee ground emesis, and it really does look like used up coffee grounds. Okay, It looks a bit red, but it just looks like there's coffee grounds all in the bowl or on the floor. Okay. So, and the first thing that we do if someone has hematemesis, when we see someone vomiting blood, ABCs, right? Are they choking on the blood? Are they going to aspirate the blood? Is their blood pressure stable? Are they tachycardic? So it's all about airway, breathing, circulation first, because you can lose a lot of blood by vomiting from an esophageal varice, a gastric ulcer, or a duodenal ulcer. Okay. So now let's just talk a bit about occult blood. So an occult blood test or occult blood means that you're losing tiny amounts of blood, either in the vomit or in the stool. Okay, not enough for us to see with our eyes, but we can use an occult blood tester. Okay, so we can put a bit of the vomit, for example, on the occult blood tester, and then we drip a little bit of a solution onto it, and it turns instantly blue in the presence of blood and iron. Okay, so red blood cell on the occult blood tester will turn blue. Okay, and the more blood there is, well, the more the occult blood tester will show blue. Okay, so it's actually called a guaiac test or occult blood test. Okay, and we use these. Say someone has come in and they're low on red blood cells, they're anemic. We may do a rectal exam, or we may collect a bit of stool and apply some of the stool onto a guaiac test, put the solution on to see if there's any blood within the stool at all. Okay, and we can do the same thing with vomit, not as commonly, but we can certainly do the same test with vomit secretions as well. Okay, so always think of melena as a upper gastrointestinal bleeding that's tracking down slowly, making its way to the rectum, and then it comes out as black stools. Okay. What else could possibly make your stools black? Well, iron supplements definitely make your stools black. Okay. Pepto-Bismol, which is a type of antacid, and people use it for an upset stomach. Well, it has bismuth in it, and bismuth, being an element, causes the stools to become black. So if someone comes in and they're on iron supplements, or they've been taking Pepto-Bismol, they may report that they have black stools. And now we have to distinguish whether the black stools are from bleeding, or Pepto-Bismol, or iron supplements. Okay, let's do this question together. A patient is vomiting bright red blood. So just visualize that. You have someone in front of you that they're just vomiting bright red blood. Okay, pretty distressing scene. There's blood everywhere. Okay, so where is the patient most likely bleeding from? The esophagus, the stomach, the duodenum, and I really hope not the rectum if it's coming out the mouth. Okay, that's quite a distance. So it's going to be the esophagus, okay, because it's bright red. If it's had time to mix with the stomach, it's not going to be bright red anymore. The stomach acid turns it into this coffee ground look. Okay. And when I say coffee grounds, I really mean it looks like that from your coffee machine, the used up grounds in the filter. Okay. So the answer is going to be esophagus. The stomach, it's going to come up as coffee grounds if there's vomiting. The duodenum, again, it'll have some time to mix with the stomach acid, and come up as coffee grounds, or if any of these head in the other direction, down the gastroesophageal tract, down the gastrointestinal tract, then they will come out as melena, black stools. Okay. So is it possible to have an upper gastrointestinal bleeding but have bright red blood out of your rectum? And the answer is yes. How could that possibly happen? Well, if you have tremendous amounts of bleeding from a duodenal ulcer or a gastric ulcer or esophageal varices, they haven't had time to get digested by the gastrointestinal tract. The blood is still relatively intact, and when it gets to the rectum, it's still red. Okay, so it is possible, but really I would think of upper gastrointestinal bleeding as coming out typically as melena.